Good afternoon, everybody. Thanks for joining us for a chat on sepsis. Hopefully, over the next 45 minutes to an hour, we'll have an informative chat about something that I think we're probably less aware of in the pre-hospital setting than we could be. So to get started, a few objectives. We're going to talk about what is sepsis, how we define it, how we manage it in both the pre-hospital and in-hospital settings. And then we'll talk about how early recognition has a positive benefit for these patients. Sorry, just letting my screen catch up here. So why do we really care? These numbers are a little bit old, as you can see, 2008, 2009, but the stats say that there's over 30,000 cases in Canada with over 9,000 deaths, and a quarter of all people admitted to the ICU are a result of sepsis. So this is a huge patient population that has a huge financial burden on the healthcare system, and a patient population that we probably are underperforming in our recognition and management of these patients. We're going to talk about some other stats later, but we'll actually see in the pre-hospital and hospital setting, we've spent a lot of time and energy on things like STEMI programs, stroke programs, and trauma bypass programs. And we're going to show that sepsis actually has significantly higher mortality rates as well as high occurrence rates, and that the treatment that we can provide to these patients is even more beneficial than some of these other programs. So we're trying to illustrate that this afternoon. I hate to start off a talk with terminology. You're probably going to agree with the bottom point, who really cares? But I think we'll realize that potentially some of the way we talk about this topic of sepsis, whether you refer to it as septic shock or maybe just severe sepsis or just an infection, that actually using the terminology correctly to make sure that we're speaking the same language effectively really makes a difference. It builds a strong foundation, and much like using common language in the setting of, say, CTAS guidelines, to make sure we all have the same understanding of the words that we use to make sure that the message doesn't get lost in translation and we actually arrive at the desired end destination. So sepsis briefly, if you think about sepsis being a systemic response to infection, and if you review that response as basically happening on a continuum, with sepsis being one of those stops or stations on that continuum, and each of those stages or stations basically has clinical features that identify what's going on at that point in time, as well as the management that's associated at that time. So this graphic illustrates that continuum, starting in the bottom left with SIRS being kind of the initial stage of that inflammatory response to an infection or a pathogen, and then moving along in severity to sepsis, severe sepsis, and finally septic shock. So the criteria that defines each of these sections and then how we address patients in each stage of this continuum is what we're going to talk about for the next little while.
And this is a really interesting slide because it starts from SIRS, which may not even reflect infection at all. So SIRS is just basically a constellation of abnormal vital signs or a lab test that can be the result of infection or inflammation, and things like pancreatitis, trauma. Those can all give SIRS criteria.
Perfect, thanks. And we've got a pretty little diagram coming up in a minute that's going to show that exactly, so that's perfect. So to get things started, we'll talk about that initial phase in the continuum being SIRS, or systemic inflammatory response syndrome. So it's basically a group of primarily vital signs or laboratory findings that highlight that response to infection or inflammation. So the things we think about as SIRS criteria are temperature, so either a low temperature of less than 36 or a patient being febrile. So temperature, depending on who you ask, of at least greater than 38. Some may say greater than 38.3 or 38.5. I think one of the things to notice here is our primary perception of patients with infection is probably that they're going to be always febrile, whereas realistically, patients may just lose their ability to regulate their temperature, and patients that actually have a low temp are potentially even more concerning.
And in specific patient populations, you may not expect a fever at all. For example, a septic infant or a person who's quite elderly or immunocompromised may have severe sepsis and not mount a fever at all.
Next, SIRS criteria is a heart rate. So whether you call, typically we think of a heart rate over 100 as being tachycardic. In this case, we're going to think of a heart rate greater than 90 as satisfying that SIRS criteria. Next is tachypnea with a respiratory rate greater than 20, or in the hospital setting, a PaCO2 of less than 32. In the pre-hospital setting, we may think of an end-tidal CO2 below that normal range of 35 to 45. Next, a lab finding in hospital is going to be either a low or a high white blood cell count, either less than 4 or greater than 12. And basically the presence of any 2 or more of these SIRS criteria suggests that patient is positive for that SIRS response.
And the importance of having 2 of those signs indicate SIRS is because there are various situations where one criterion or another won't apply to a patient. For example, a person on a beta blocker might not mount a tachycardia. A person who is, as I mentioned, young or old may not mount a fever. And so this is a syndrome. You don't need all 4, just 2 of them to qualify for SIRS.
This next graphic illustrates what Elena mentioned earlier, is the fact that just the presence of these SIRS criteria alone, being abnormal vitals, doesn't necessarily indicate that this is only the response to an infection, that there's lots of other scenarios, some normal in the case of maybe a patient who's in the middle of a jog and has an elevated heart rate and an elevated respiratory rate, as well as something abnormal like pancreatitis, burn, trauma. There's lots of causes of these SIRS criteria. So don't necessarily let it be misleading. It's obviously going to be your overall evaluation, including history and physical exam, that's going to paint that picture and help you determine the actual process that's going on, whether it's presumably of an infectious origin or something else.
As we're going to hammer home a few times in this talk, the most important thing is that you're aware of it and that you can identify that it's present.
So the next stop on our continuum after SIRS is going to be sepsis. So the only difference between sepsis and SIRS is that this patient not only has at least 2 of those SIRS criteria that we just talked about, but they also either are known to have or are believed to have some type of source of infection. So building on that last point we just talked about, there's lots of other causes of SIRS criteria or abnormal vitals under the SIRS criteria. But when you add those abnormal vitals with a suspected infection, some of them are listed below, and we're going to talk about them more in depth later on in the presentation. But you combine those SIRS vitals with a known or suspected source of infection, and now you have a patient who's septic. So I think that's probably one of the key terminology things that we can take away from this, that we've probably used the term sepsis before, potentially inaccurately, given the indication that we're talking about here. The next stop, certainly in increasing severity, is going to be a patient with now severe sepsis. And this patient not only has obviously the SIRS criteria plus a known or suspected source of infection, but now they're also having significant signs of either end organ dysfunction or tissue hypoperfusion. So those are going to manifest themselves in any one of several manners. Basically, only one of these needs to be present to identify a patient as having severe sepsis. Again, you don't have to have basically all these tick boxes. Low blood pressure is one I think we're all pretty familiar with. Altered mental status, that may be vague confusion. It may be more severe to the point of basically unresponsiveness. Patient may have decreased urine output. In the pre-hospital setting, certainly a little more difficult to gauge, but in hospital, you're going to be looking for less than 0.5 ml per kilo per hour. Going on for greater than 2 hours is what we would consider decreased urine output. You can have a patient potentially with low SATs, even with oxygen administration, or you may have a high lactate level being greater than 4. as an indicator of the patient being severely septic. There's some other criteria relating to acute lung injury or ARDS that's primarily measurable in the hospital setting, but I don't think we'll spend too much time here. Coagulopathy as well. And finally, the last stop on this continuum and the most sick of our patients is going to be somebody who's now in septic shock. And so the septic shock in building on the first 3 stages, obviously they have SIRS criteria, they have a known or suspected source of infection, they have signs of end organ dysfunction, and now finally you've already initiated treatment, primarily being aggressive fluid resuscitation. We'll talk about what that means in a little bit, but basically after those initial resuscitation steps, their condition doesn't necessarily change or improve. So these patients are the sickest of the sick. You can see there that they have an extremely high mortality rate in the neighborhood of 46 to 50%, even with treatment. And what that treatment actually represents, we'll get to in a few minutes.
And septic shock reflects an important nuance here. Severe sepsis can be reflected by low blood pressure or a lactate that's greater than 4. Septic shock are those people who've been identified to have those issues. We've challenged them with the fluid resuscitation. We'll talk about amounts in a few minutes. And they have persistently low blood pressure or persistently high lactate. That's an indication that these guys are very sick.
And I think we've got a couple of poll questions now for you to review some of these indications. So we'll work through those together.
Sorry, Mike. So I just actually launched the first poll. So the question is, identify the stages of the infection continuum in order of increasing severity. And you'll see 5 options there. So take a quick look at that. We'll give you maybe 20 or so seconds, and then we'll show what the results are. All right, so we've had about 80 of you that have voted. And your results are showing 80% have chosen option B, which is SIRS, sepsis, severe sepsis, and septic shock. So well done. So that was the correct answer. Did you guys want to talk about that answer or move on to the next poll?
I think we're just going to move on to the next poll.
All right, let's do that. All right, so the second poll question has now been launched, and the question is, which are included in SIRS criteria? So again, we've got 5 options. All right, so the majority of you have answered, and you've got 88% of you answering correctly. The answer was E, all of the above. So again, well done. All right, back to you guys.
Sounds good. Thanks, Steph. So hopefully that's a quick review of those criteria for each stage. And now we're going to move on to a really brief overview of the patho of sepsis. So if you think about sepsis being infection and it being a severe systemic interaction between a pathogen and a patient's immune system. So in the setting of a localized infection, so maybe you have a puncture wound from a sliver or something small, the introduction of that pathogen produces a localized immune response that has mechanisms that basically infiltrate that site and try and, with the goal of controlling that invading organism and then initiating repair. And so you have neutrophils and monocytes that do that, and they do that by releasing inflammatory mediators, produces local vasodilation, increased permeability of your vessels, and also some activation of your coagulation pathways. So that's your normal response to a localized infection. Think about sepsis being a systemic infection, so now it moves from being local to being throughout the body, and basically that immune system response goes into overdrive, and now your systemic response to that causes widespread effects, same as they happen in the local setting, but now on a much larger scale. So again, you have increased vascular permeability, vasodilation, thrombosis, and you have potentially significant hypotension and lots of end organ dysfunction that happens. And it's basically a positive feedback loop that the more of this damage that occurs, you get a further activation of inflammatory and coagulation cascades, and that damage perpetuates itself. So again, if you take nothing else away, basically consider it an exaggerated systemic response to infection, with the response to that infection causing as much or more of the damage as the actual infection.
Some of the important characteristics that you might notice in a severely septic patient is that increased permeability causes all the fluid to leak out of the blood vessels where it should be into other parts of the body or the third space. So people will have potentially crackles in their lungs. You'll notice that they might have low blood pressure because that blood's not in their circulatory system any longer. The blood vessels become quite floppy, and so the patients lose the ability to vasoconstrict and elevate their own blood pressure. You'll see that these patients, whereas if you see a trauma patient who's losing blood onto the street, their hands and feet are going to be quite cold because their blood vessels are vasoconstricting to try to push blood to the vital organs. In a septic patient, those blood vessels are quite dilated, and so blood is just pooling everywhere and not being shunted to important areas. So their hands and feet will be quite warm. It's a distributive shock, also known as a warm shock, and that's an important distinction in a patient with a low blood pressure. You can determine pretty much only sepsis and neurogenic shock will give you warm extremities and low blood pressure.
Great, thank you. So moving on, the challenge in sepsis patients, and I think is the big reason that we underperform as a system, both pre-hospitally and in the hospital setting, is the challenges associated with actually identifying these patients. We talked about the SIRS criteria being kind of non-specific, depending on where you interact with this patient on that continuum of their infection. A lot of the early signs and symptoms are fairly vague, subtle, non-specific, and it's easy to be missed. And especially, just to make it a little bit more complicated, is the fact that our elderly patients, who are one of the highest risk groups, don't necessarily mount the same response. And so the symptoms that you might expect to see from a severely septic patient may not be there in an elderly patient, despite the fact that they're very acutely ill. So it's easy to overlook it. Some of the important things, Elena's just touched on things like warm versus cold shock, some of the physical exam findings that we're going to talk about, and we're going to talk about it in a little more detail, kind of a site-specific finding, so I'm not going to get into it too deeply here, but obviously history and physical is going to be our main criteria for coming up with a differential of some sort of infection or sepsis. People that are at increased risks, extremes of age, you'll see on the next slide something to illustrate that, so I'll talk about it then. Obviously, patients with lots of comorbidities that have concurrent medical challenges, as with anything else, diabetes, coronary artery disease, other pathologies tend to have a synergistic effect, and these patients are much more at risk for severe infection. Patients who are immunosuppressed, whether that be long-term steroid therapy, patients undergoing chemotherapy for some type of cancer process, patients who have, they're probably going to be patients who are on steroids, but patients who have autoimmune conditions, whether that be rheumatoid arthritis, lupus, something like that. And then any other patient who's had just some type of major insult to their body, so maybe that's a burn, some type of trauma, they've just had surgery. All these patients are at increased risk for that sepsis, as well as basically anybody that has tubes, lines, or other non-natural devices inserted as part of their medical management for whatever condition.
That's exactly right, Mike. And as the exception that proves the rule, you can also have sepsis and have none of those risk factors.
Again, just to make it difficult. So this illustrates basically those extremes of age that we talked about being a risk factor. Certainly under 1 year of age, again, being more challenging because they don't necessarily mount the same symptomatic response, but are no less acutely ill. And then certainly once you get into higher ages, even starting as low as maybe in the 50s, certainly getting in the 60s, 70s, and 80s, that these patients, as you can see, account for a large number of patients with sepsis. We alluded to some of the mortality rates at the beginning of the presentation as part of the discussion as to why we should care about sepsis. And so to contrast heart attacks, strokes, traumatic mechanisms, which is what's got a lot of our attention and energy over the last years, you can see mortality rates there ranging, we'll say, in the neighborhood of 10%. Obviously some variation that you can see in each of those conditions. And then we move back over to the left and we see that patients with severe sepsis have a mortality rate of 20%, and that patients with septic shock have a mortality rate of 46%. Despite basically the best interventions that we can throw at them. So obviously it's a significant process that certainly warrants attention.
And the literature will have a variety of mortality rates depending on which paper you read, but the real take-home message is that it's always high.
And then some of the things that other factors that impact not only whether you get sepsis, but basically how you're able to do in that course of the sepsis with dealing with infection and getting through the treatment and trying to get over the process. Some similarities there. Extremes of age, particularly elderly, tend to not do as well. The type of organism that you're infected with makes a difference. Some are much more aggressive or invasive than others. Your overall health and immune status, whether basically the duration of vasopressor treatment, if you need it beyond 1 day, that tends to be a negative factor. And once you get multiple organ systems involved, then that certainly is more concerning as well. So I think we have another poll question here.
Yep, we do, and I've just launched it. So this poll question is a straightforward one, true-false question. Only patients with risk factors such as extremes of age or immunosuppression may experience sepsis. The group seems to be quick to answer this one. So we've got 95% of the audience choosing the answer B, false. So again, well done.
Great job, guys.
I think one of the most impressive things, as having worked, I guess, a few years in Emerge now, is the patient that comes in and looks relatively well. They're 50 years old, not 80, and they have a single abnormal vital sign. Their lactate comes back at 4, and half of them an hour later look like $1 million. Their heart rate's 80, and they're on their way up to the ward. And the other half, you're intubating them an hour later. And I still, I don't think I'm doing a good job, even after 5 years of residency and 8 or 9 years in practice, of being able to pick out which one is going to need to be intubated and lined kind of an hour later. So I envy the work that all the medics do pre-hospital, but just keep your spidey senses up and try and figure out it, because it is very difficult to figure out who's going to get really sick really fast in this patient population.
Exactly. Just not taking for granted the fact that they look well now, that they're probably not sick, that if we have a high suspicion for a severe progression of this disease, then we'll probably be more effective at recognizing them early and hopefully getting a head start on that treatment.
All right. So
I think we got one more poll question. Is that right, Steph?
Nope, not till later, actually, Mike.
Oh, my apologies.
All right, just keep making sure you're on your toes, Steph. So, we've talked a little bit about what sepsis is, and we've talked a little bit about pre-hospital assessment. I'd like to chat now about how we manage sepsis in the emergency department. And one of the things that I think will be exciting for you will be that a lot of what we do as physicians in the emergency department is very similar to what can be done in the field. So I'm working an evening shift, and a crew brings in this patient and says to me he's got some abnormal vital signs. We're concerned about sepsis. So just like you, my assessment always starts the same way, assessment of ABCs. If they're unstable, I intervene. If they're stable, I can move on. I then do my history, my physical exam, my lab testing, my diagnostic imaging. At any point along that pathway, if there's something that needs to be treated, we jump in and we treat that. That stuff's all fundamental. We're not going to spend any more time on it. The really interesting stuff starts when we talk specifically about sepsis management. If you've read any of the literature out there, it all started, or at least became interesting again, when Manny Rivers did his big paper a number of years ago. And his process has been refined and simplified such that there are 3 key principles that we really focus on for sepsis management. So let's get into that a little bit more. Early identification. This is something that, as we've mentioned a few times, isn't necessarily as easy as one may think, because patients with sepsis can look well despite their underlying pathophysiologic process. So we've seen this slide before. This is the continuum, and really the only way we're going to identify SIRS, sepsis, and then potentially severe sepsis, septic shock, is to know this continuum and know, what constitutes each phase of it. And we need to know that there are exceptions to SIRS criteria, and that we only need 2 of those criteria to qualify. So it's about keeping your spidey senses going. That patient, if this was what happened when we put him on the monitor, it's pretty obvious that this is a sick guy and he's in septic shock. And if everyone was that easy, I'm sure that our mortality rates from sepsis would be much lower. So once I've identified that there are SIRS criteria present, my brain needs to start thinking over, where's the source of infection? Could this be sepsis? This is a diagram showing a number of common infectious sites. Of course, there are going to be more than what are listed here. For example, Mike talked about indwelling lines. The guy in this diagram doesn't have a PICC line, but that could be a potential source of infection. If we look at the data that's calculated from the Canadian Institute of Health Information, they've put out some interesting stuff. For example, a person with severe sepsis, so just to review, that's a person who meets SIRS criteria, has a source of infection, and now has some element of organ failure. A person who meets those criteria and in severe sepsis is going to have predominantly only one system failing at the time that they're seen in the emergency department, 62.6% of the time. 27% of patients will have 2 systems failing, and then an unlucky 10% of patients will have 3 systems or more. Now, if it's one system that's going to fail, which one is it going to be? Half the time it's respiratory, and half the time it's renal. And fortunately, those systems are not too hard to pick up. So, if a patient comes in short of breath, with crackles in their lungs, with a history of a cough, needing supplemental oxygen, there you go, that's your organ failure. If a person comes in complaining of UTI or with a history of oliguria or anuria, you've got your source, your organ failure right there as well. Altered mental status is brain failure. So even though the central nervous system is failing in only 10% of patients according to this data, don't forget that confusion is organ failure of the brain. So once we've identified that this person is suffering from something on that sepsis continuum, we need to treat them. And there's really 2 prongs to this treatment approach. Our priority is early antibiotics. This is the part of treatment that's been shown to save lives. Depending on where the source of infection is, we're going to choose a broad spectrum antibiotic initially, and once cultures have come back, we can narrow that down. This paper is probably one of the most important papers of the entire webinar. This talks about how important antibiotics are. So what they looked at here was mortality and how it was affected by delay in antibiotic administration in people with septic shock. So these are patients, just to hammer this home one more time, who had a blood pressure with a mean arterial pressure of less than 65 millimeters of mercury, despite initial fluid resuscitation, in this case 2 liters, or a lactate greater than 4, despite fluid resuscitation with 2 liters. Those people had a survival rate, if antibiotics were given initially, of 80%, so 20% mortality. But for every hour that antibiotics were not given, survival decreased by 7.6%. So you can think about how easily we can miss that. If someone has a transport time of 30 minutes, then it takes 20 minutes for them to get set up in the ED, and it takes me as the physician another 20 minutes to assess them and figure out what's going on. You know, that person's already had an hour pass and their mortality is increased by 7.6%. So this is an area where pre-hospital personnel can really impact patients' outcomes by tipping us off right off the bat and getting them to the hospital quicker.
I was going to wait and see if anybody asks the question. I don't know if anybody has yet, but we'll maybe preempt that a little bit. And I'm sure somebody out there is saying, well, then why aren't paramedics giving early antibiotics? And I think in an ideal world, that's a place that we may go. Certainly there is research being done out there to evaluate whether pre-hospital antibiotics is a safe and effective treatment option. So I think we'll have to stay tuned over the next little while to see what that research hopefully fairly conclusively decides. And certainly there's lots of stages that have to occur before we could get to that here, certainly with increased baseline education in recognition and identifying these patients, with then the ability to act on some of the more advanced treatment modalities. So stay tuned over the next little while. Certainly that's our hope that that's where we'll get, but that's why we're not doing it tomorrow.
Yeah, lots of exciting things to come. So patients been identified as septic. I've identified a potential source and I've given my antibiotics. The next priority, which in reality is probably being managed simultaneously in our environment with multiple hands on deck, is we want to fluid resuscitate the patient. This is the second most important slide that I'm going to discuss. And if you remember anything, just remember this image. Aggressive fluid resuscitation is a vague term. So first, let's talk about which fluids we use. There is a lot of literature out there talking about normal saline versus Ringer's lactate versus albumin. In the short term, there's absolutely no difference between normal saline and Ringer's lactate. In the long term, there may be differences borne out, but for the purposes of this talk, you can consider either fluid to be safe and effective and can start what is available. Let's go. So then the question really becomes, how much fluid should we give? And there's been a lot of research looking at this as well. This paper, for example, looked at a target mean arterial pressure of 65 to 70 versus 80 to 85. And the patients with the lower mean arterial pressure of 65 did just as well. So what does that translate to in the field or in the emergency department? You're going to give a liter of fluid and you're going to see what the blood pressure does. If it improves over to higher than 65, then you may want to slow down how quickly you're giving fluids. If they're not meeting that MAP blood pressure target and they're not in pulmonary edema, you're going to give more fluid. If you need to give 2-3 liters, that's fine.
I think to equate that to what we're used to in the pre-hospital setting is our typical medical directive is a patient with a systolic blood pressure of under 90, we're going to give them a 20 ml per kilo fluid bolus. So that directive stands, and that evidence, that paper that Elena just showed, is a perfect example of the fact that we're okay to give 20 mils per kilo, and that we want to shoot for just a normal blood pressure. We're not shooting for higher than normal pressures. There's no reason to do that. It also goes to show that when we talk about aggressive fluid resuscitation, paramedics are used to thinking about 20 mils per kilo as kind of their aliquots that they give boluses in. We get uncomfortable when we start giving more than one or maybe two of those boluses, certainly obviously checking for those signs of fluid overload and failure that we talked about. But these septic patients, probably we won't have time to get to it in the pre-hospital setting, but it wouldn't be unusual for these patients to receive 60 or even 80 or potentially even higher mils per kilo of fluid over the course of their resuscitation.
And a lot of the research shows that over the first 24 hours of treatment, so that would include pre-hospital care, emergency department care, and then potentially ICU care, these patients can receive 6 to 10 liters of fluid over 24 hours. But just getting back to the emergency department management, if I've given a patient 2 liters of fluid and the blood pressure is not meeting that mean arterial pressure goal of 65 millimeters of mercury, that sets off a red flag in my head. That says to me, this person is in distributive shock. This person's blood vessels are probably unable to provide the vasoconstriction required to mount to sufficient blood pressure. This is a patient who's going to need a vasopressor. So then the question becomes, which vasopressor should I use? And there's research out there, for example, this paper showing that norepinephrine is superior to something like dopamine. Does that mean you can't use dopamine? Of course not. If that's what you have available and your patient needs a vasopressor, you're going to give them dopamine. If you're in the emergency department and you have the luxury of choice, then perhaps you're going to reach for the norepinephrine. Now, we had a question come up.
On the point of dopamine and Levofed, it's interesting. Dopamine's available in prepackaged bags, so the ACPs that are listening, or any CCPs, will carry dopamine, or might most likely carry dopamine. But norepinephrine, you still have to mix it up, so it's not really that feasible to use pre-hospital, especially with the short transport time. So for Dr. Iguano and I, we asked the nurse to mix it up, and a couple minutes later it's there and running in an infusion pump. Practically, it's much more difficult in the pre-hospital environment. A couple questions have come in. One related to, is there any side effects to giving antibiotics and giving them to someone not suffering from possible SIRS or sepsis, which I think is what you were alluding to, Mike. Any drug has side effects, unfortunately. So we know that even a single dose of antibiotics comes with the risk of diarrhea of about 10 to 20%, depending on the antibiotic that you use. And the more significant side effect would be C. diff diarrhea, and then any allergic reaction or anaphylaxis. So it's not without potential harm in giving antibiotics. So the decision isn't it's not one to be made lightly. If you talk to the infectious disease specialist at LHSC, they're resistant to sort of broadly giving antibiotics versus the people that are trying to get our sepsis mortality down want to just give everybody antibiotics. So it is quite a medical dilemma right now.
And on the grand scale, so there's the side effects that Dr. Ducalo just mentioned of things like diarrhea, in some women yeast infections, allergic reaction. That all happens at the single patient level, but on a population level, broadly giving antibiotics to patients who perhaps don't need them can contribute to the generation of superbugs, which everyone's heard about in the news and is concerned about. And so while we do not want to miss septic patients and delay their treatment, we also do need to be judicious.
And this actually leads into the second question that was asked around are clinics and other environments prescribing more antibiotics because of sepsis data? And the short answer is I don't know the answer to that question. If I were working in a walk-in clinic or a family doctor's office, or even the lower acuity patients that we see in the emergency department, I'm very judicious, or should be very judicious, with who I give antibiotics to and who I don't. I try my best not to give antibiotics to likely viral syndromes in the absence of someone having sort of SIRS or sepsis criteria, because of the side effects, the allergic reactions, the broad resistance. So if anything, antibiotic use in the non-septic patient has decreased or should be decreasing in a community practice. That being said, if someone's got SIRS or sepsis criteria, they should get them and should be at a hospital. So that deals with the two questions that have come up, guys. So I think there's a poll next, maybe, or
Yep, I believe so.
Yep, there is, and you guys were correct. I was not on my toes, and I did miss a question before. So this is actually the question that we should have asked about 10 minutes ago. So we'll see if you guys are listening and still remember the data that I think Mike had shared at the time. So the question up there now is mortality rates for patients with severe sepsis and or shock are blank in relation to the mortality rates of MI, CVA, or trauma patients. All right, so we'll share the results of that. We've got 59% of you saying 2 to 4 times higher, and that is the correct answer. So great job there. We do have 2 more poll questions to share right now. So here's the next one. So the poll question up right now is identify the key principles of sepsis management.
Come on, everybody, make me proud.
And that they did. We've got 94%.
All right.
Answering correctly. So great job there, guys. And we've got 1 more poll question for right now. All right, and that one is launched. The question up there now is what fluid volume may be required to provide aggressive fluid resuscitation to a septic shock patient?
Thanks to Mike for providing the info on this one.
We'll see. At least don't say 1.5.
No one's saying that quite yet, nor will they now. So here are the results on that one. A little bit more widespread, but the majority of you are answering correctly with up to 60 mils per kilo.
And I take the blame on that because I was doing a lot of speaking in terms of liters of fluid. And obviously, mils per kilo is a slightly different way of thinking about fluid administration. But I think the point is that I can maybe make a bit more clearly now is that a lot of these patients, some patients may do well with a single bolus of 20 mils per kilo, but most of them will require more, and it would not at all be unusual. In fact, it's to be expected that they could require 60 mils per kilo.
Yeah, but Scott Weingart is a popular podcaster out of New York City on emergency medicine and critical care that advocates basically giving septic shock patients 4 liters of fluid up front, even in favor of putting them with pulmonary edema if you need to, and then fixing it after. Not that I'm suggesting.
That's not quite what we're advocating in a pre-hospital setting. But
the extremities or extreme possibilities.
And Scott also functions in basically a critical care unit within the emergency department, so he has a number of tools at his disposal, but he's a brilliant guy with lots of good things to say. So those are the fundamental components to what we do in the emergency department for treatment of sepsis and septic shock. There are also many other things that we can try. The evidence is not as strong to support the use of these things, but very frequently patients will have received central venous catheterization. This picture demonstrates internal jugular or a subclavian venous catheter, or it shows both actually. And, you know, the research has shown that putting these lines in the initial management phase does not contribute to saving lives. It can be very useful for the patient who has had their initial treatment because they may require a number of different medications and fluids to be run in, and these lines have a number of different ports and can add a margin of safety for things like vasopressors. So this can be a very important part of the patient's care algorithm, but it's not something that must happen immediately. I won't spend too much time talking about blood because this is something that I would very rarely even give to a septic patient in the emergency department. This is much more frequently used in the intensive care unit setting. But the basic principle is that in patients with severe sepsis and septic shock, the ability of the blood to deliver oxygen to the organs is diminished. So I'll say that again. The ability of the body to deliver oxygen to its organs is diminished. And there are a variety of reasons for that. And with certain advanced indicators, we can see when that ability has become dangerously weakened. And so intensive care teams will administer blood products to boost that ability to deliver oxygen. I think that's all I'll say about that. We talked about organ failure in severe sepsis and septic shock, and the heart is an organ. And so if the heart is failing to provide enough cardiac output through contractility, for example, then medications like inotropes can help boost the cardiac output and thus support blood pressure. So things like dobutamine or milrinone, you might see getting used in the emergency department and more frequently in the intensive care unit. There are a number of other medications, but the evidence for those is even less. So I've sort of skipped over them for today, but we could definitely talk about it another time if you are interested. So since we've talked now about what we do in the emergency department, I hope that you can see a lot of parallels to what can be done in the pre-hospital setting and what some of the major benefits of recognition of sepsis in the field can be for patients. People have even gone far enough to do a paper on the topic, saying that, yep, there's a lot that can be done. One thing is decreased transport time. Really, one of the main goals for sepsis patients is to minimize their time to antibiotics. And so we can talk about administration of antibiotics in the field, but even before we get that fancy, like we said before, some septic patients will look very sick and some will not. And if you're the hotshot paramedic who can identify that person who meets SIRS criteria and has a source of infection and potentially is having some difficulty breathing or is a bit confused, and you get that person to hospital, tell that triage nurse that you're suspecting severe sepsis, and tell the emergency physician the same thing and get that person treated faster, you are very potentially contributing to saving that person's life.
And to make sure that we're speaking the same language, again, we talked about terminology before, to kind of highlight the importance or the acuity of the patient, is that somebody on the lower end of that spectrum, maybe SIRS or sepsis, is probably going to be a CTAS-2 patient, but somebody on the more severe end, being severe sepsis or septic shock that really is showing those signs of end organ dysfunction, should be labeled as CTAS-1. We tend to think about CTAS-1s as primarily being just VSA patients or close to VSA patients, but these are patients that really are in need of immediate and aggressive resuscitation, and so we should be flagging these patients as CTAS-1 to make sure that severity or acuity is appropriately conveyed to the receiving facility.
If you look at the actual CTAS criteria, as soon as your oxygen sats are less than 90% or you're confused from baseline, you're almost guaranteed to be a CTAS-1. Arguably, we make about pre-hospital 2% of patients CTAS-1, and in hospital, at least in London, about 3%. If you do it based on the actual criteria, it should probably be closer to 4 or 5%, because we are on the side of making people a CTAS-2 that are, as you mentioned, Mike, that we make people who are dead or nearly dead, we make them CTAS-1s, where the potential benefit for the CTAS-1 that's a little bit less sick but still fits the criteria is probably higher.
The other part of sepsis management that can very easily be done in the field with really no change or minimal change to existing algorithms is fluid administration. And if you're not sure or not comfortable giving more fluid than an initial 20 per kilo bolus, you can always patch in and ask. But fluid is important, and if you think that person might need it, you can use your judgment and initiate that. And
I think the interesting thing is that the medical directives we have that guide our fluid administration in the pre-hospital setting very closely aligns with the guidelines for sepsis management, right? So it's, I think, another example of we can take some stock in the fact that these are appropriate directives in this setting.
We're not the only people who are interested in pre-hospital sepsis management. And if you take a look at the literature, there are a number of papers out there documenting various initiatives that have taken place. papers looking at IV access and fluid resuscitation, papers looking at EMS contributing to time to antibiotics, looking at point-of-care lactate levels to find those cryptogenic septic shock patients who maybe have a normal blood pressure, but that lactate's 5, which qualifies them as a person in shock, and for that CTAS-1 categorization. Another interesting thing is end-tidal CO2 is actually showing promise as an analog for a point of care or a serum lactate, and patients with certain end-tidal CO2 levels can be identified as having septic shock just by that modality. So lots of interesting things to work on.
And just to jump back on the bandwagon as far as fluid from a pre-hospital perspective, even the patients who maybe don't have that hypotension yet and don't truly qualify for our fluid bolus in the field, even the recognition that this is potentially a sepsis or a patient who's somewhere on this sepsis continuum, presumably in the first half, given that they maybe don't have hypotension yet, that even that recognition combined with the fact that pre-hospital we may start an IV, even if that's only a normal saline lock, that the literature that's out there actually suggests that patients who get that IV, even without additional fluid administered pre-hospitally, that they actually have a decreased in-hospital mortality rate as a result of that. So don't misinterpret what I'm saying. I'm not suggesting that every patient we transport should be getting an IV, not at all. That's not without risk. But in this particular patient subset, the patients who were suspicious of this being the issue that's going on, that even a pre-hospital IV without additional fluid actually positively impacts outcomes. Presumably, it gets the attention of the receiving facility, and it makes it easier to facilitate the beginning of that fluid and that antibiotic administration once they actually get to the hospital. Looks like we've got one question that we can talk about regarding end-tidal CO2. And so we talked about early on in the SIRS criteria about PaCO2 being the arterial measurement of CO2 being less than 32 as qualifying for that SIRS criteria. So end-tidal CO2, although not guaranteed to be directly correlated, typically would be in the same range. So in our normal, quote unquote, normal patients, our EtCO2 range is going to be between 35 and 45 millimeters of mercury. So in the septic patient or the patient who's got metabolic acidosis, we're going to see those end-tidal values being low. So depending on who you ask, that might mean less than 32, it might mean less than 30. More severely, it may be 27 or 25. But basically a low end-tidal, like Dr. Iguano mentioned, is really showing to be potentially a positive, yet still to be tested method of identifying and determining the potential acuity and potential mortality of these patients. So basically, if you combine, I don't know if we probably can't poll who doesn't have nasal end-tidal CO2, but my impression is most of the services in our area fairly recently have gone to having that nasal end-tidal CO2 available for no longer just being available for intubated patients, but it's actually a really great additional vital sign to be aware of. And any patient that you're suspicious of, if you happen to combine that with a low end-tidal CO2, that's kind of the icing on the cake as far as validating that concern about a patient being somewhere on the sepsis continuum.
And of course, nothing's ever as easy as it sounds. End-tidal CO2, as we all know, can vary from second to second based on a patient's status. And so I can't say that I know yet for how long it needs to be measured before you can actually confidently say what the value is. So lots of potential there, and probably just a little bit more work needed before it can be rolled out confidently. Would you guys agree?
Yeah, for sure.
All right, so we're getting to the end. This is a pretty depressing image here, and I am really hopeful that with the education that we've provided today and are providing to physicians and nursing teams in the hospitals, we can help change that patient's outcome to something more like this. So we have 3 cases here just to really cement some of the concepts that we've talked about. I want you to consider this woman here. She's 55 years old and comes to the emergency department or has called an ambulance with the concern of general malaise. Her medical history is significant for hypothyroidism, and for treatment of that, she takes her Synthroid. You can see her vital signs there. Now, given this talk that we've just run through, what would her diagnosis be? I don't think we can poll it, but I'll just give you 10 seconds to think about it, and then we're going to show you the answer.
So we're looking for what stage of the continuum is she on potentially?
If you answered sirs, we're really, really proud of you.
So our next patient, we have an 85-year-old male who presents with an altered LOC. He's got some dysuria and hematuria. He's got a medical history significant for some renal cell carcinoma, and he's currently taking prednisone. His vitals, as you can see, temp of 38.3, heart rate tachycardic 117, 120 on 80 for a pressure, and a respiratory rate of 29. So where on that continuum does this guy fall?
So if I'm just going to work through this algorithm here, he's got a fever, he's tachycardic, his blood pressure looks okay. I'm not sure if he's normally hypertensive, but I'll assume that for him that's normal. And his resp rate's up. So he's got 3 abnormal vital signs. One important thing to pick up on here is that he's got altered mental status, which could be construed as brain failure. So that's organ failure there. And he has dysuria and hematuria, which makes me very suspicious that this guy's got a urinary tract infection. So there's my source.
So that all leads up to severe sepsis. If that's the answer you got,
way to go.
We're on the right track. One more, and then I think we have 2 poll questions for you.
So it's the 61-year-old male who a family member activated EMS because he was complaining of abdominal pain, nausea, vomiting, and diarrhea. He has a medical history of significant for peptic ulcer disease, and because he's been having some pain, he's been taking a lot of Advil. A lot. You can see his vital signs. He's febrile. He's tachycardic. Whoa, that is not a good blood pressure. And his resp rate's 18. So where in the continuum is this guy? So right off the bat, I can see that he has 3 abnormal vital signs, and one of them is blood pressure that's not meeting the MAP goal. So he's going to be a severe sepsis or a septic shock, depending on how he would respond to fluid there. But I'm worried enough about him, I'm going to think he's a septic shock. So then where's his source? Abdominal pain, peptic ulcer disease, and NSAIDs? Perhaps this guy has a perforated viscus. So he's got infection in the abdomen until proven otherwise.
Excellent. So, like we said, if you got to severe sepsis or septic shock, then again, we're on the right track. Steph, I think we've got 2 more poll questions if you're ready for them, and then we'll open it up to questions.
Yep, we do. So I've launched the first of the last poll questions. Question up right now is, what is the primary reason for early identification of severe sepsis or sepsis shock for improved outcomes? Looks like your message is ringing loud and clear because we have 100% of the audience answering correctly with B, mortality rates increase with each hour prior to antibiotics.
That must have been too easy.
Or the lesson was a good one.
Or we just have a brilliant audience.
The last question I'm going to launch right now, and it's up there. The question is, what is the mortality rate associated with septic shock?
I think this is where we need the Jeopardy music.
All right, we have our results. We've got 76% answering correctly with 45 to 50%. So again, well done, guys.
And that's a tough one because we've mentioned a few different mortality rates through this talk, and that's because various centers with their various research projects will publish different numbers. But as long as you knew that the mortality was high, you're on the right track.
So that basically concludes what we wanted to talk about today. We'll let you ask any questions if there is any in a sec. I think the takeaway point, if you remember nothing else from a pre-hospital perspective, that although hopefully at some point we'll get to a point where we potentially have more advanced treatment and kind of directives that we can work with, that I think we're actually on very solid footing at the moment with the medical directives that we have as far as fluid and potentially dopamine administration for the ACPs. And that even more importantly, the most significant thing that we can do for our patients is actually, like Dr. Duclos said, have our spidey senses working kind of in overdrive and have a high index of suspicion for these patients. Recognize that they're potentially somewhere on this sepsis continuum, and then communicate that to the receiving facility, because it's actually that time to treatment and the early recognition that is going to have the most severe impact. Severe is maybe the wrong choice of words, but the most positive impact for these patients. So even if you do nothing else other than point out to triage that, hey, I think this patient is probably sepsis based on identifying the criteria that fits them on that continuum, that's probably the best thing we can do for them at the moment.
So I don't actually have any other questions from the group. And so with that, I'd like to say thank you to Elena, to Adam, and to Mike for all the work that you guys have put into this. I think it was a great webinar. We have some positive feedback coming through saying, thanks, great job, well done. For anyone who's interested, the PowerPoint presentation and the webinar will be posted on our website. If you do want to have to look at it again, it will be up there. Do keep an eye on our website, on our social media, and we will post more information about any other upcoming webinars. Otherwise, thanks again for attending, and have a great afternoon. Take care, guys.
Thanks, everyone.
Take care.